Good morning. This is Dr. Lara Jehi, and with me today is Dr. Hussam Shaker. We are both privileged to be with you in this new episode of the Neurology Video Journal Club to discuss this paper, the factors predicting outcome after intracranial EEG evaluation in patients with medically refractory epilepsy by Dr. Sivaraju. I am a practicing epileptologist in the Cleveland Clinic Epilepsy Center. I've been in practice for over 20 years. My research interest is in outcomes research following epilepsy surgery, trying to understand what drives these outcomes, the mechanisms of seizure and other outcomes following surgical procedures. I am happy to turn it over now to my co-discussant, Dr. Shaker, for his introduction.
Thank you, Dr. Jehi. So I'm Hussam Shaker. I'm now an epileptologist in Trinity Health, Grand Rapids, West Michigan. I did my training in Cleveland Clinic. It was more focused on stereotactic EEG, and I'm currently director of stereotactic EEG program here in Trinity Health. My main focus is stereotactic EEG, intracranial EEG monitoring. So the topic, you can tell, is very interesting, and I'm very excited to discuss it with Dr. Jehi.
Great. Thank you, Hussam. So let's dig in, shall we? We're going to talk about a few things today. This is a remarkable paper, I have to say. It covers a very important topic to us now in the epilepsy community, that of what happens next in patients who have epilepsy that is so bad that they needed to undergo an intracranial, an invasive procedure, an intracranial EEG evaluation to come up with a surgical plan. The main highlights of the paper start with a definition of what determines those outcomes. First, what defines the subgroup of patients who do end up with a resection after going through an invasive EEG evaluation. This is table 1 on this slide. And then following that, what determines seizure freedom following the resection in those patients, and that is table 2. And as you can see, there is a whole list of variables that were identified on the initial screening with a univariable analysis. But at the end of the day, what came out following a multivariate analysis, which controls for all possible confounders and interactions among these variables, it really boiled down to 3 things. At least that's what stood out to me. Then we'll see what stood out to Hussam. What stood out to me was that the main 3 drivers of outcomes in this patient population boil down to accuracy of localization. Specifically, they were having a lesion on a brain MRI. Second, they were having a hypothesis that localized to the temporal lobe. And then a resection, and then epilepsy in the non-dominant hemisphere. If you really think about it, all those things boil down to we really had a good idea of where the epilepsy was going in. And it wasn't a part of the brain that we were most likely to be able to completely remove because it's in the temporal lobe and it's in the non-dominant hemisphere. Hussam, what did you take away from this initial, high-level view of the paper?
Yeah, as you said, the paper is very interesting, and it covered long period of time. And from the beginning of the paper, they focus on important issue of the referral thing to the surgeries, to the intracranial. Then we will come down to the result. So you in the past, Dr. Jehi, you published papers about the cost effectiveness of going to phase 2, going to the surgery. And since 2003, AAN, they recommended to send all refractory, difficult epilepsy, they don't respond to medications, to go to send level 4 center that they have surgery, they can go through phase 2 or intracranial EEG monitoring. It's sad that still surgeries is still underutilized, even a lot of efforts to increase the number of referrals. And they mentioned that in the introduction, that still the surgery number is still low. And even in the study, 25% of people who went to intracranial EEG monitoring did not end up with the surgery. Part of the referral issue, like some like uninsured population or racial minorities. But coming also to complication, people are concerned about complication of the surgery because it's still brain surgery. Yes, it's minimally invasive with stereotactic EEG, but it's still brain surgery. And what's interesting, Dr. Jehi, from this paper, when they talk about the complication in this paper, it was about 7%, which is, generally speaking, above other papers. Like the average is 4% in Cleveland Clinic, putting things together, and mostly asymptomatic bleeding from the electrode itself. But if you focus on what they mentioned, the most complications came from the first half of the study before 2009, and which I think I'm a practicing SEEG doctor, that around that time we have the robotic assistant SEEG, we have better OR frames, so we are much better doing phase 2 or intracranial EEG monitoring nowadays. Coming back to your point, I 100% agree with you. These 3 points, what you mentioned, this is the most important we see in our practice, in our patient management conference. And in the beginning of the paper, they mentioned about their inclusion criteria. And they put in the beginning about the people who have discordant data or insufficient information, they went to phase 2. So now I will circle back to you to see, starting with, there's a lot of argument about if I have discordant data, should I go? Or my understanding from the paper, it was partially discordant because the methodology of stereotactic EEG, at least, like you need a concordant data. So how do you see that reflected on the result, on the outcome?
Yeah, Hussam, those are both points you bring up are really interesting. So the first one about safety of intracranial evaluation, I think this paper is an excellent example of the fact that right now in 2023, the practice of invasive intracranial EEG evaluation, particularly with stereo EEG, is a very safe procedure. As you mentioned, the complications that were there were all in the earlier days, more than a decade ago, when the current technology is not available. So I would say my takeaway from that point is that in the current day that we live in right now, the concern about safety should not be a deterrent towards referrals for invasive evaluations. And if anything, what you do with an invasive EEG, with a stereo EEG, even if you don't end up with a resection afterwards, is you're at least giving that patient a chance to have their epilepsy localized and to have it be treated. So I don't think safety is an issue, and this paper supports it. The second point that you bring up is that about the importance of the hypothesis being, the concordance versus discordance business that you bring up. The way I would think about it is that you need to have a hypothesis, and this is what this paper actually confirms with the concordant hypothesis, the solid hypothesis going in being a solid predictor of a resection and then seizure freedom afterwards. Those are very challenging patients. Nobody is going to get to the point of an intracranial EEG recording if their epilepsy was easy, right? Like if it was completely straightforward, why do this? So of course, these are patients where we have difficulty with non-invasive data localizing where their epilepsy is coming from. But as long as we can use all of that non-invasive data to form a cohesive, a cogent hypothesis for where that epilepsy is, and then use that hypothesis to plan where the electrodes are going to be implanted, we're good. So if we don't have a good expectation of what the answer is going to be, we should not be asking the question. Same as with anything. If we don't know where the epilepsy is or think that we know, we have a good hypothesis, just slapping electrodes everywhere and expecting that the answer will materialize itself, that doesn't happen. And that's how, I interpret this. There was another point here that I think is worth discussing, and that is the point of defining the outcome itself, meaning what do we consider as success in this patient population, given how sick they are, and what we've discussed. In this paper, they consider, complete seizure freedom, I think, or an Engel score of 1, as being the success measure. And I'm interested in your thoughts about that. Actually, I think there was a graph, a figure that shows the outcomes. So what are your thoughts looking at this?
Yeah, it's very interesting. They set the bar very high. The primary outcome, like seizure freedom, as you said, the ILA class 1 or 2 or Engel 1, which is we all dream about. We hope that our patient go no seizures, no side effects from medication or complication from the surgery. This is the goal that we hope. But in reality, some population of our epilepsy patients, they are very, very difficult, especially the one who were born with some brain malformation, some intellectual disability. These very hard to achieve that. So I think quality of life, and they discuss that, like should be considered. And that's why I feel it's very hard to have standardized prediction scale, because every patient is a different story. And some patients who have seizure every day, if I get them back to seizure every week or seizure every month, maybe I think it will consider a huge success. People who are having disabling seizures or frequent generalized tonic-clonic seizures, if I can get them to only small focal seizures without impaired awareness, that it will consider a success. So it's very hard to define success in epilepsy and refractory, focal or multifocal epilepsy, even decreasing the risk sometimes of SUDEP, sudden unexpected death of epilepsy, getting the patient to chance to drive. If we eliminate seizures that affect awareness, and this you see here in this figure, going back to that data, it's very interesting that, so you see people who went through resection, which means they had a good hypothesis, then they got good focal intracranial EEG finding, then we were able to remove the tissue, so there was no functional issues there. They did very well. So they went up to like 70, above 60%. And people who went to only medical treatment, about 7% seizure freedom in over 5 years. But more interestingly, people overall, the whole cohort here, the red color, it looked to people who went to phase 2, and they found overall, it's about 42% seizure freedom in 5 years, if you put the whole cohort together, regardless of resection or not resection. And that's very interesting point. So is it because we understood the epilepsy better? So now we are tailoring our treatment? Is it we are changing the medication that we understood the epilepsy during wakefulness, during night, during sleep? Then we were able to target seizures. Were we able to do maybe getting patient to neuromodulation based on the data? So it's telling me that going through a thorough investigation and focusing on every patient, giving the time to focus on every seizure and doing all these workup, it was very helpful. Even if they don't go to resection, like you see, a good number of patients did not go to resection, but overall, everyone went to phase 2, they did better.
Yeah, those are great points. I mean, definitely one obvious finding in this paper is that resection really trumps everything else. If a patient is a candidate for a resective approach, there is no question that they should be getting a resection. You see here how superior the rates of seizure freedom were in people who had a resection. There is a point that is made also in the paper about even the patients who were considered to be challenging, who did not have these 3 criteria that they identified for favorable outcomes. So people who were non-lesional, who had extratemporal epilepsy, where the hypothesis was challenging, etc. Still, whenever they had a resection, more than half of them were seizure-free at that 5-year mark. So a challenging localization, a challenging patient should not be a deterrent to undergo an intracranial evaluation. And a challenging localization on that intracranial evaluation, if there is a window for a resection, should not be a deterrent towards a resection. Not going through a resection is really choosing the easy way out at this point. Another follow-up, to the points that you were making about the value of an intracranial evaluation per se, that is something that I think this paper is sort of just beginning to scratch the surface of. It is definitely a future research direction that one should look into to understand the indications of an intracranial evaluation when perhaps resection isn't even going to be considered. So for example, really defining the role of an intracranial EEG prior to a neuromodulation therapy, or looking to see how could you optimize the planning of an intracranial evaluation now that this paper confirms what we've all known, that having that hypothesis and implanting these electrodes where they need to go is really critical. These are just a couple of the future direction questions that come up from reviewing it. That's not to say that the paper does not have any limitations. To be fair, we have to talk about that too. I'd say the one limitation I saw from it is that at the end of the day, it really reflects the practice and the expertise of one surgical program, right? So it's always a leap with this type of research to think about how do those findings generalize and apply in other surgical programs who may have different philosophies for planning their intracranial evaluations and making decisions regarding the output of those intracranial evaluations, with decisions about who goes to CERT, who goes to resection, who goes to neuromodulation, and who continues with medical therapy. And that's not really taking away from the value of it. At least it's asking the question and it's bringing the conversation that we're all having right now. I just think that it motivates us, if nothing else, to be doing this work at a larger scale. I'm interested to see what you thought was the, a limitation you took away from it.
Yeah, it's I agree with you. And at the end of the paper, you see that it's very hard to have standardized prediction scale that we can use, because every patient is different. And as you said, we are all biased every program has a vision how to approach epilepsy. Some program, they go more to neuromodulation. They do phase 2 to know where to target. It all depends, I think, on the education that everyone got. We are all biased about what we learned. And the other point of the paper, it's also, they found that the best indicator for seizure freedom is focal intracranial EEG finding, which with this thing, it varies between people. So so it requires a lot of training to focus on the intracranial EEG onset. So what I consider focal, you might consider no. If I do extra analysis, I will find. So it's very subjective. And the other thing also, the way they approach, the way they did intracranial monitoring. Most programs now, they use stereotactic EEG. In the paper, they mixed stereotactic with a strip and a grid. The number of contacts was like a little bit high, above the average, was like 246. So yes, there are some limitation to paper, but that's a part of our life. That's a part that we see it on daily basis.
Yeah, absolutely. Absolutely. The point you made about education is really key. I mean, if nothing else, it's very obvious from this paper and others how critical it is for us to continue to learn and train our epileptologists on how to interpret intracranial EEG recordings and how to plan and design, translate a hypothesis into a good map, a good implantation map for intracranial recordings, and how critical it is for us in parallel to train our neurosurgeons so that they are facile with all of the new technology of functional neurosurgery, minimally invasive approaches, but at the same time, retain the skill set that they need to perform resective epilepsy surgery, given the superiority that we keep demonstrating over and over with how superior resection is to the other approaches in patients who are candidates, whether they have temporal or extratemporal epilepsy. So we all have a lot of work to do, I guess. And we all have a lot to learn and to teach. And with that, I'd like to bring us to a close for this journal club, and thank our audience for listening, and encourage them to read the paper and read. There's a very nice editorial linked to it in Neurology, and to watch for future programs within the Neurology Video Journal Club. Thank you.
Thank you. Thank you.